or if all else fails, you have a grab bag listing. And that is pretty much the way the disorders are. It's actually an evolving classification. So as I said, we've gone all the way from DSM-1 to DSM-5. I don't know when DSM-6 will come out. 5 has not been out that long. But you can be assured that when they come out again, it will be grouped yet another way, and they'll have more diagnoses put together. There are actually clusters of personalities, and they're kind of grouped together, and we'll present them in these same little runs. But you have cluster A, which are individuals that appear odd or eccentric. You have cluster B, where the individuals appear dramatic, emotional, or erratic. And then you have cluster C, where the individuals appear anxious or fearful, as just kind of broad appearances for these folks. In the cluster A, you have paranoid, schizoid, and schizotypal personality disorder. This will be a little bit harder for you to distinguish. And then cluster B, antisocial, bad people, borderline, bad people, histrionic, interesting people, narcissistic, you won't like to interact with them so much, but you'll identify. And then the final group is avoidant, dependent, and obsessive-compulsive personality disorder. Please be sure to make this distinction. There's an obsessive-compulsive personality disorder, and then there's an obsessive-compulsive disorder. So we went over an obsessive-compulsive disorder. It has its criteria for the diagnosis to be made, but an obsessive-compulsive personality disorder is not the same thing. There's many features that are common, but there's a distinction to be made there. Okay, what are personality traits? Well, they are enduring patterns of how a person sees the world and how they relate to the world. This is your formal definition. Enduring patterns of perceiving, relating to, and thinking about the environment in oneself that are exhibited in a wide range of social and personal contexts. Thus, this is just the way they see things wired and how they fit into it, the whole thing. Only when a personality trait is inflexible and maladaptive and causes significant functional impairment or subjective distress does it constitute a personality disorder. It's very much like every psychiatric disorder we've talked about. You can see elements of a lot of things in your own background, but unless they reach the level of disruption and somehow destroy the way you normally interact in the world, work world, family relationships, it does not reach a level of a diagnosis. Here's an example of what it means. You look at a personality trait, they operate on a continuum from what's considered normal, acceptable in your culture, all the way through what's considered pathological. So let's say we have an obsessive-compulsive trait. I'll talk to you about my obsessive-compulsive traits. Every one of you has some obsessive-compulsive traits. If you don't, you're just not telling the truth. You won't be here if you didn't have something that was a little bit driven within your personality. And I know that Professor Brooks and Professor Rourke have no traits of obsessive-compulsive. She's hiding, going low. By the back door, it's okay. So let's look at these. And the trait is being conscientious. Okay, we would all say being conscientious is actually probably a pretty good thing to be. But let's see how it can evolve over time. Adaptive. I like to take my time and do things right. Okay, that's being conscientious, and you're kind of adapting that to job at hand. Subclinical. Sometimes I think others will disapprove of me if they find even one small mistake. Okay, not quite the best or healthy adaptation. Then disorder. I find it hard to stop working until I know others will be satisfied with the job I've done. Okay, now that's your satisfaction, your personal satisfaction is related to what somebody else is going to think. So now you're kind of driven over here, driven by somebody else's thoughts. And then finally, severely disordered. I check and recheck my work until I'm absolutely sure that no one can find a mistake in what I've done. Okay, kind of like an SPBL write-up. Okay, don't get this is for the faculty side. Okay, you do what you can do, but then in this case, it's disordered enough that you just really over-attach to it. Okay, let's look at diagnostic criteria for a personality disorder. Okay, an enduring pattern of inner experience and behavior that deviates markedly from expectations from the individual's culture. And we've been talking all along about culture kind of defining behavior. You know, there's an element of subjectivity to any of these diagnoses when you get into it. And so if you're being subjective with somebody who's not from your culture, then you might misinterpret their behavior patterns in a way that is pretty normal for their group, for their cultural group. So you kind of have to be aware of that. But the pattern is manifested in two or more of the following areas: cognition, how they think and put facts together, how they process information; affectivity, that's the range, intensity, lability, and appropriateness of their emotional response. And again, that's highly culturally linked. Interpersonal functioning, how you get along with other people; and then impulse control. Okay? There are cultures where impulse control is not as strong as it is in I'd say, in a white Anglo-Saxon culture, it's more tightly controlled. But there are other cultures that are much more expressive, expansive, and they will say things and do things fairly reactively in a way that we would go, my goodness, that's too much. But that's not too much for that culture. So again, think about it. But if you look at this, it's a pattern, it's an inner experience, so it's what they're thinking about themselves on the inside, and then also how they behave, what you see on the outside. So there's really an interior and exterior evaluation that has to go on to actually make a diagnosis. Okay, now, general diagnostic criteria for a personality disorder. The enduring pattern of that personality is inflexible and pervasive across a broad range of personal and social situations. Inflexibility is a very important word to remember, and it's not just isolated in one or two parts of your life. It's pervasive. It's fixed. The enduring pattern leads to clinically significant distress or impairment in social, occupational, or other important areas of functioning. I think this is probably cut out and pasted in almost every diagnosis that we've seen so far. The pattern is stable and long duration. They might be inflexible and pervasive, but they are consistently inflexible and is pervasive across the board, and it lasts a long time. It can usually be traced back at least to adolescence or early adulthood. Like I said, you know, as the brain and behavior matures, what you see is what you see, and most of those diagnostic criteria start locking down about mid to late teens, early 20s. You kind of know what you have. The pattern is not attributable to another mental disorder, condition, or physiologic effects of a substance. Okay, why do healthcare providers need to understand about personality disorders in the first place? Well, it's important because it can improve your patient-provider relationships. If you don't really understand who's sitting there, you may keep interacting with them the way you want to interact with somebody, and you may keep getting the wrong responses, and you want to know what's wrong with them. Well, it may be what's wrong with the way you interact, or what's wrong with the way you receive back from them. So it will help you, and I'm telling you, the more you can understand who's sitting in that chair, the better off you are. It's one of the first things I want to know. I tell students all the time, when you go into a room with somebody you've never seen before, it's an exploration. Not only of what their complaint is, but who are they? You know, what's going on inside. It enhances compliance, adherence, whatever words you want to use. Well, you are more likely to find a way to get that person to move towards healthy behaviors if you understand what motivates them in the first place. How are they wired to process information? And then finally, it can reduce patient stress. You know, if you're inflexible in your personality, and let's say you're a healthcare provider with a personality disorder, there are some out there, and then you keep putting yourself on somebody else, you know, maybe you won't keep a job, maybe you get bad evaluations, maybe you just hate your job. There's a lot of things that can happen if you don't know, but it can certainly stress a patient. The pathology of personality disorders affects predisposition, presentation, course, and prognosis of clinical syndromes. So what they are is somewhat predictive of how they end up. Okay, let's just start looking at them. Paranoid personality disorder. What do you think you're going to see in that? Just off the get-go. What's that?
10 hats.
Say that again.
10 hats.
10 hats and say more about that.
It's like people are reading their minds, like when the government can listen to their thoughts.
Okay, so they're suspicious of what people are thinking or doing in relationship to them. What else would you expect? Anything?
Thoughts of persecution.
Yeah. Yes, somebody might be doing something, they're out to get me. They're not in my best interest. And that can happen. Would that be a good thing if you're a healthcare provider? And they think they're being persecuted and you want them to do something or take a medication? They may be wondering what you're doing to them. Okay, here's the criteria. A pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent. Now, I think it'd be pretty hard for a paranoid personality disorder to receive care because they would have to trust you. And you go in there as if you will be trusted, and they may not be trusting you at all. I think these folks are a little bit easier to pick up. Y'all think when you had them, just Professor Roark, Professor Brooks, paranoid personality, just the way they react to you, maybe. Okay. They have to again have early adulthood and forward. They have to have 4 or more of the following to actually make the diagnosis. They suspect without sufficient basis that others are exploiting, harming, or deceiving him or her. So exploitation in healthcare might be you're ordering tests for me that I don't need, you're using me for research, that type of a thing. They are preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. So they're worried about this all the time. They're reluctant to confide in others. That's the problem as a patient. If you can't confide in your healthcare provider, how are you actually ever going to really figure out what they need? They're afraid the information will be used against them. They read hidden, deep meaning or threatening meanings into benign remarks or events. Like you go to a paranoid patient and go, and you're just kind of joking, oh, we just don't even know what Joe's up to. What do you mean by that? What am I up to? And so you're just playing, and they're, why'd they say that about me? Wonder what they're thinking when I leave the room. And it just goes on. It's like, nothing, I was just joking. But it would come out that way. They persistently bear grudges. They're unforgiving of insults, injuries, or slights. Whoa. What was that? We have failure of cooling, failure of the system. Oh no. It could be. They perceive attacks on their character or reputation that are not apparent to others and is quick to react angrily or to counterattack. They have recurrent suspicions without justification regarding the fidelity of the spouse or sexual partner. How many people have gotten divorced because one of them thought the other was having an affair and they just, where did you go? Why were you gone for 3 hours? I didn't see the car up there. I saw the car at that house. What were you doing? It just goes on. And, without anything going on, they've actually created something going on. Does not occur exclusively during the course of the disorder with psychosis and is not due to a general medical condition. Okay, let's see what this looks like.
My name is Jordan Jackson, and I have paranoid personality disorder. I would say this all started when I was walking to work one day, and I felt as though this man was following me. And I'm 95% sure, no, I'm 100% sure that that man was following me. He was this man, and he was 6'4", he was black, and every time he just walked near me or walked in my vicinity, I was petrified. And if I turned a corner, he turned a corner. He was just chasing after me no matter where I went. And it has affected my life in many ways. An advantage of being as paranoid as I am is that I'm always cautious, and that means I'm always safe. And that's honestly the best thing you can do because there are so many people out on the street that can't be trusted. A disadvantage of this would be is that I don't really have a personal life or a social life because I don't get a chance to connect with people because I don't trust them because people can't be trusted. This is the most contact I've had with somebody in a really long time. One thing about my disorder is that I am constantly moving because I have a tic and I always feel the need to look over my shoulder and see what is happening because you never know who's near you. Another thing is that I don't trust a lot of, wait, hold on, sorry. I don't know if you guys see that, but there was movement over there. That's the stuff you have to be careful for because you never know. You never know because the person behind you could be a killer, could be a rapist, could be a mugger. Always be cautious of your surroundings.
So is somebody actually following her?
I don't think so. I don't think so. That's, she's actually saying something was happening with a peripheral vision. I don't know, maybe there was somebody that was moving the trees, but I don't think that would come in after her, but she interpreted that as coming after her. Okay, so that's kind of an uncomfortable diagnosis to have, or a personality trait. How many people have it? 2.3 to 4.4% of the population, believe it or not. Men are affected more often than women. And the first several personality disorders we're going to talk about are men predominating over women, but in the end it will catch up and balance out. We don't have them all. They're not all in men. It often appears in childhood, adolescence, as you expect. Odd behaviors attract teasing, as you can well imagine. Maybe more common in family relatives of people with schizophrenia, because you know that paranoia is one of the features that you see in more full-blown schizophrenia. So it could be more common there. And then members of minority groups, immigrants, political and economic refugees, or individuals with different ethnic backgrounds may be inaccurately labeled with this disorder. And again, that's a cultural dissonance. They come and they get labeled as being paranoid, but if you're in a country where you aren't originating and you're wondering what's happening and you're more jumpy about stuff and you're asking questions, you look like somebody who's paranoid. And I can tell you, when I went to China, I didn't speak anything. I mean, you're totally lost. If you're on the street and people are looking at you, you start looking at everybody, I'm telling you, you don't know stuff, you don't know the language, you don't know what's going to happen to you. There's so many people moving around that you kind of looking around and watching, you never feel quite settled in. And it's not paranoia so much as it's hypervigilance for a good reason. You don't know exactly what to expect, so you look like there's something wrong with you. Now, I may look like there's something wrong with me anyway, but in China, I really look pretty. Okay. How do you interact with a patient with paranoia? Admit mistakes. Okay, don't try to slide one by. Be forthcoming and honest. Have a professional demeanor but not overly warm style. Because what if you got really close to a patient and we're just overdoing it a little bit? What might the paranoid person think? Why are you doing that to me? You're too close. What are you trying to do? Why are you acting that way towards me? That would be odd behavior to them. It's different from the norm. So you have to be more the norm and just really maintain that professional style. Don't confront them. Set limits. Clearly explain procedures, medications, results, why you're going to do this, what the value of this is. Yes?
So these patients don't have like an event that triggers them to be paranoid, they just develop the...
It's the way they begin to relate to the world. No, there's no triggering event with that. Okay? So it's a little bit different than schizophrenia and those other psychotic disorders. Okay, We made reference to schizoid personality during the schizophrenia, and I told you we'd come back to it. So let's just look at schizoid personality disorder. You might recognize this. These people come across to me as odd, and schizotypal really comes across to me as odd, and you will find, and I don't like to label people, but more than I kind of want to know where I think you're operating from. So here, a pervasive pattern of detachment from social relationships. These are not the party people who are attaching all the folks in the room. They're not doing that. And they have a restricted range of expression of emotions in interpersonal settings. I get frustrated with people who are like this because I like to interact and see a response back. I told y'all that I like to feed off the cues the person gives me. And when you're with somebody with schizoid personality, they aren't going to just give you back anything. It's like, well, so glad to see you, and they might just be hello, or it's just, or if they do anything, it's like, ugh. I don't thrive off of that in particular. Okay, they have to have 4 or more of the following: neither desires nor enjoys close relationships. Isn't that sad? Including being part of a family. They're just there. Almost always chooses solitary activities. Has little, if any, interest in having sexual experiences with another person. Takes pleasure in few, if any, activities. Lacks close friends or confidants other than first-degree relatives. They tend to be in the family. They're just the odd person in the family, and that's it. Appears indifferent to the praise or criticism of others. So you could say something, or, you know, you're doing really well, I'm so proud, I'm so happy for you. And they look at you. All right? You know? And then shows emotional coldness, detachment, or flattened affectivity. Okay, this is not part, you have to rule out these other diagnoses, schizophrenia, etc., blah, blah, blah. And if criteria are met prior to the onset of schizophrenia, you can add pre-morbid. Schizoid personality disorder, pre-morbid. You'll see that for a couple of these, that it's a personality disorder that can be identified, but maybe it advances into full-blown schizophrenia. Maybe it doesn't. Most don't, but they could. And there's a lot of schizophrenia in families anyway. So let's see what this looks like.
Urine.
Oh, it's the tree?
Yeah.
Yeah, it looks really good. Why did you choose the tree?
Oh, it's dead. And you can see all the branches. It's better than the other ones. You can't see it.
Oh, alright.
Yeah.
Do you live really close to it?
Yeah. Just back there to the left.
Oh, right. Yeah, that's really close to you. Oh, you can't. Oh, yeah, it's gone. Are you going to Rachel's party on Friday?
No, I don't think so.
I don't have anywhere to go. You have to go with parents. Because it's like, boring or something.
No.
Are you busy?
No. Don't know, just don't fancy it.
Right. Yeah. Sorry. I'll leave you to it then.
Good.
Struck out. You see how he didn't want her touching him? And there was no interactive potential there. Okay. So he wasn't interested in interacting with her, didn't want to be touched, didn't take up any cues, kind of sat by himself. And, you know, that personality type might even progress to more pronounced forms of being very isolated and standoffish. She probably betrayed you because he was still kind of good looking and young, and she didn't really know. Well, now she knows. Okay. Let's see. Okay. Let's see the next one here. Okay, it's. You know, I don't know if I believe this, but this is what DSM-5 says. Prevalence is 3.1 to 4.9%. Do y'all believe that? Do you believe that? I mean, I was kind of taken aback by that. It might be in a fairly low form, you know, not so pronounced as what I'm thinking of. Diagnosed more often in men than women, there you go, may have increased prevalence in the relatives of individuals with schizophrenia or schizotypical personality. Here's some people who may have had this disorder: Albert Einstein, Mary Todd Lincoln, Charles Darwin, Sigmund Freud. I find that interesting that Sigmund Freud might have schizoid personality because he did so much writing on dreams and eroticism. And if you're a schizoid, you don't really have any interest in it. Why would you be so fascinated that way? Maybe it's just kind of a scientific, clinical fascination as opposed to anything else. Stephen Hawking, Bill Gates, Karl Marx, Bobby Fischer, the chess player.
Can we say Stephen Hawking? Like, he had ALS. We don't know if he was sexually interested or not.
But you know, earlier he had a different life. He wasn't always like that. So, isn't there a movie about Stephen Hawking? It's, what is it called?
The Theory of Everything.
Yeah, and in that there actually was, you know, kind of an isolation over time. How do you interact with a person with schizoid personality disorder? Understand their need for isolation. Don't push things. Minimize new contacts and intrusions. Maintain a quiet, reassuring, and considerate interest in them. Don't insist on reciprocal responses. So that would be my challenge, would be to be okay with communicating in a very professional way without trying to do too much, and being okay that that was okay, that that's what worked better for them. Okay, schizotypal personality disorder. I use this picture elsewhere. That looks like Damien from The Omen. Okay, no, it's kind of an interesting, odd little face right there. Okay. this is a pervasive, this is a little bit more extreme than schizoid, a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as by cognitive or perceptual distortions and eccentricities of behavior. The thing that separates schizoid from schizotypal or schizotypal is this cognitive perceptual distortion and eccentricities. They both have problems with relationships, desire to do it and doing them, but it's this other more bizarre piece that you're looking for. So here's the 5 or more things you have to choose from. Ideas of reference, excluding delusions of reference. You remember what a delusion of reference was? What is that? What is delusion of reference?
Because it all applies to you.
Yeah, everything applies to you, but in a delusion, is it, do you believe it's real? In a delusion, you believe it's real. Here's just an idea of reference. So there's the difference in knowing that everything is referring to you versus orienting yourself towards everything referring to you. Odd beliefs are magical thinking that influences behavior and is not consistent with subcultural norms. For example, superstitious belief in clairvoyance, telepathy, or sixth sense. That's kind of weird, but it's very pronounced in them. Can be. Unusual perceptual experiences, including bodily illusions, okay, what they think they are, etc. Odd thinking in speech, vague, circumstantial, metaphorical, over-elaborate, or stereotype. You would talk to a person that was schizotypal, and you would go, what? I mean, it would just be kind of odd from the way you would organize your thinking. Suspiciousness or paranoid ideation. Inappropriate or constricted affect. So they're odd behavior, or it's very limited and tight and drawn in. Appears as odd, eccentric, or peculiar. Lack of close friends and confidants other than first-degree relatives, and when you're around them, you can understand why. They probably have a hard time drawing them, but they also don't live them. And then excessive social anxiety. That really doesn't diminish. They just have a problem being around people. It's uncomfortable. Okay, does not occur exclusively during the course of schizophrenia, a bipolar disorder, or depressive disorder with psychotic features. So you're ruling out that it's all these other things, but these are the lingering behaviors that that person would have. Again, this one can also be labeled pre-morbid. Schizotypal personality disorder pre-morbid. So let's see what that looks like. We may not do all of this work.
I understand that you had a change in your work at the library from working back in the stacks to now working out at the front desk. Is that right?
Yes.
Can you tell me more about that? What that's been like for you?
Well, my supervisor is pretty busy, and he doesn't like to be bothered. He already thinks I'm not suited for the job.
He said something to you about that?
No, not exactly. But when I'm with him, I can sense that my customers have complained.
How is that?
Well, when they ask me something, I tell them. But I don't make small talk. I guess I've always been a Pluto, out beyond the rest, encircling,
Bizarre.
ever watching, and seeing more in the darkness than the rest.
I talked to your sister briefly, and she said that she hasn't really noticed any changes in you, that you're pretty much the way you usually are.
Constancy is a virtue.
Are you friends with any of your coworkers?
Well, I did have lunch once with some of them. But I've been reading such depressive books lately that when I think about them, it upsets their meal. They can feel my feelings. So, I eat by myself.
Have any of your coworkers been helpful to you recently about this move from the stacks to the front desk?
Well, we don't talk.
If you do have something you want to talk about, with whom do you talk?
I guess the last person was my college roommate.
In what way was he helpful?
I'm not sure I understand what you're asking.
You said that your college roommate had been helpful to you if you needed somebody to talk to.
Not that often. And mainly about studies. We both worked very hard in school. I could often tell what he was thinking, and I knew when to leave him alone.
Where is he now?
He died.
When was that?
A few years ago.
How did that happen?
I'm not sure.
Think this murder.
We didn't talk after graduation. I remember reading about his death in an alumni magazine. And I remember receiving a feeling that something had happened to him even before I read that story. I already felt he was dead, and often felt as though he were in the room with me. Then, when I read that story, I understood.
What did you understand?
Well, I threw his picture away just before he died.
Have you had any new or puzzling sensations recently?
Well, from time to time, I can smell a very disagreeable odor. I'm concerned that it's coming from me. It worries me.
What do you do about the odor?
I take a lot of showers, but the odor, it's malicious, piercing.
Does the odor hamper you in any way?
Well, recently I've tried to avoid getting too close to people when I'm at work at the desk, especially girls.
What sort of contact do you have with women?
Well, several work at the desk. From time to time, I don't like this room. I can sense an evil spirit in here.
What were you feeling just then?
Well, I guess I was distracted by the specks on the wall and how small they are in comparison to the entire wall. I was thinking about distance, proportion, and size. I'm fascinated by outer space and the proportion one can see there. I was just there a minute.
Do Do you have you ever seen a psychiatrist or a psychologist or some other kind of counselor before today?
No.
Do you ever see or hear things that may not be there that other people don't see or hear?
Do you ever hear things or see things that other people don't hear? No. Oh no. I had an uncle who drank heavily, and he would hallucinate.
Trying to get a schizophrenia
But I do not drink or use drugs.
What's happening?
The director of public libraries mailed me a letter this year saying that we should keep up our public image. Somehow, I think he knew I had been reading D.H. Lawrence.
Do you think the director of city libraries knows what you read?
No, I guess not. But I bet he wouldn't approve.
Do you know if anyone else received a letter from the director of city libraries?
I don't know. But if he thinks by my working at the front desk is ruining the library's public image, then I'll quit.
That's enough. How did that person make you feel?
Uncomfortable.
That is really creep you out. Okay, let me go back on this thing just a little bit. Isn't that weird? Okay, do y'all know anybody like that?
No.
I actually have been around, you know, if you go long enough, you'll see a lot of things. I've seen that. Have you had anybody like that, Professor Brooks, Professor Rohr? That's just really odd. Go back and look at this thing. Okay, you've got ideas of reference, odd beliefs or magical thinking. We had the Pluto thing, and they can.
That was a good reference.
Yeah, they can. It was the whole collage of it. You know, they can hear what I'm thinking. I think outer space.
I had a patient in GI that wouldn't eat, he was way out there. He wouldn't eat apples that were grown in the state of Washington because of the nuclear fallout in Japan. That water was washing up on the shore in Washington State and changing the apples somehow. So he could only get his apples from the East Coast.
Yeah.
Like, oh, that's okay. So we had to go to a special place to buy them. To make sure they were from the East Coast and not from the nuclear water-fed Washington apple.
Isn't that bizarre?
Yeah, you can't argue with them. You just say,
Wow.
that's smart.
So that his belief was kind of strange. His sense was he had this thing about he's like projecting thoughts. They know my thoughts, I know their thoughts. There was some kind of a quality that he could pick stuff up. Unusual perceptual experiences, including body illusions. Well, he smelled bad and he knew evil in a space and stuff like this. Odd thinking and speech. Well, he was very odd. Very stereotyped in one because he kind of kept going from side to side, very slowly, side to side, kind of moving his head up and down just a little bit, not a lot. Suspiciousness or paranoid ideation. They were going to get him off that front desk. Well, duh. You know, you can kind of figure it out. Inappropriate or constricted affect, he definitely had that. He had almost no range of emotional expression. Behavior that is odd, eccentric, or peculiar, lack of close friends and confidants. Last person he talked to was his college roommate 2 years ago. How would you be if your roommate was that? I'd call my parents and say, I'm coming home. I mean, just think about that. You know, you don't know what you're going to get in your room. Lack of close friends and confidants, excessive social anxiety. He actually seems to project some anxiety in that space. I mean, I got anxious watching his behaviors. It was just kind of not all feeling good. Okay, enough on that one. But it's kind of interesting. 3.9 to 4.6% of the general population, again, family relatives. Now, how do you interact with them? Principles are similar to those with schizoid. They often have misperceptions of physical symptoms and treatment. You know, he was making some kind of smell that was a problem. You know, do not ridicule or judge them, respect their need for privacy. Okay. Antisocial personality disorder. Okay. We'll be sure we're not at the break time. 1:50. It is break time. Get out. Take 2 minutes. We'll come back. And we'll start with 10.